Hello all, welcome to another episode of our Study MRCM YouTube series. Today we have the topic Sepsis-6 and Septic Shock Pathway. Sepsis, as you all know, is not just a medical emergency, it's a global health crisis. It has claimed a lot of deaths, almost one third of the deaths in the past. And we have been seeing a lot of cases in our emergency. How many of us manage sepsis in an effective way? That is a question to be asked to ourselves. Studies have shown that sepsis is not being managed properly in the ER, not being managed quickly in the ER. Each hour delay in management of sepsis has caused or has shown to cause the increase in mortality of more than 8%. And studies have also shown that only less than 30% of the population who comes in sepsis receives the entire 6 steps of the Sepsis-6 bundle. So today we'll discuss about Sepsis-6 bundle, which comprises of three therapeutic and three diagnostic steps, which will help in effectively managing screening and managing the sepsis in the ER. To start with, we will discuss about few definitions. Sepsis guidelines have been changing. There have been few definitions which have been used or which was in practice for quite a long time. Some of them lost its way, some of them lost its relevance. Now they are not being used. Like, for example, severe sepsis or SIRS, all those things are less used or not being used right now. The current terminologies which are used, some of them are like we have infection. Infection, as you all know, it's the invasion of body tissues by disease-causing microorganisms. Now we have uncomplicated infection. Here, infection is there, but it doesn't result in an organ dysfunction. Infection not resulting in a new or worsening organ dysfunction, which the organ dysfunction is denoted by a change in SOFA score, which we will be discussing in the coming slides. Now, the definition of sepsis. Sepsis, the current definition is life-threatening organ dysfunction caused by a dysregulated host response to infection. Clinically, this is denoted by a change in SOFA score more than 2 points. On the other hand, septic shock is defined as a subset of sepsis in which particularly circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. Clinically, this can be identified by vasopressor requirement to maintain a MAP of more than 65 plus a serum lactate of more than 2 millimoles per liter. Even that lactate persists even after adequate fluid resuscitation. So 2 points, MAP more than 65, uh, the vasopressor requirement to maintain MAP more than 65, and serum lactate more than 2 millimoles per liter even after fluid resuscitation. So we have seen the definitions of infection, uncomplicated infection, sepsis, as well as septic shock. Now, how do you screen or how do you initially manage sepsis in the ER? For that, we have a few algorithms which we will discuss. Before that, we will discuss about the common infections precipitating sepsis. As per the studies, we can see that almost 50% of the infections are due to community-acquired pneumonia, maybe community-acquired pneumonia or hospital-acquired. Then we have around 20%, which is related to skin, soft tissue, related to the urinary tract or urosepsis. Again, most of them are hospital-acquired. Then you have skin and soft tissue around 10%. You have abdomen-related causes around 15%, and the other causes like meningitis and endocarditis are a minor cause around 1 or 2%. So as you can see, the majority is either pneumonia or urinary tract. Now, as I told earlier, how to initially screen and how to initially manage. We have few scores. One of them is news 2. We'll come back to this after discussing the initial screening. Now, this is what we do in the ER, or this is what we are supposed to do. So, acute assessment starts with here. So, the zero step or the first step, we have to start when we are suspecting sepsis, and the screening has to be started if any of these factors are present. Like, for example, if the news 2 score has been triggered, that is what we saw in the earlier slide. We will go back to that once again. Or there is a carer or a relative concern, or recent chemotherapy, or there is a risk of pneumonia, or patient looks unwell to you, or there is an evidence of organ dysfunction. For example, there is a lactate which was done in the previous hospital and which is more than 2, and assessment gives a clinical cause for concern, though. So any of these are present, then that is a trigger for screening. So you have to screen for sepsis if any of these present. Now we will see over here, news 2 has been triggered. So when is the news 2 getting triggered? So you have the news 2 score here, and this gets triggered when it is more than 5. The aggregate score more than 5. Now let's see the components of news 2 score. Here we have respiratory rate, as you can see, ranges from 0 to 3, and on both sides. Then you have respiratory rate, that is the first parameter. We have oxygen saturation. There are two scales, scale 1 and 2. Scale 1 is for normal patients, scale 2 is for uh, hypercapnic respiratory failure patients, like, for example, COPD patients. So where the expected SpO2 is around 88 to 90%. So you cannot score them like the normal patient. So there are two scales over here. Then we have, again, over here, there is a score for whether the patient is on normal room air or oxygen. If it is oxygen, straight away the score goes up to 2. Then systolic blood pressure comes in. Again, on both sides, if it is less than 90, it's around 3, and more than 220, it's again 3. Pulse comes as another scoring where you have pulse rate less than 40 and more than 130 on both sides, and in between intermediate score you can see. Consciousness, if they are alert, it's 0, and anything less than alert, that is confused or verbal or pain or unresponsive, it is 3. And temperature, again, the normal temperature range is described as 36 to 38. Less than 35 is 3. And the intermediate score, as you can see, more than 39, that is 38 to 39 is 1, and more than 39 is 2. So aggregate score of 5 triggers the news 2. News 2 trigger gets triggered when the score is more than 5. Now we have two more triggers, two more things related to the news 2 we will see later. So now any of these are present. Now we have to comprehensively assess risk. So we have to measure lactate and calculate news 2 using the latest vital sign. Recheck the vitals once again and check the news 2 score. Now the second, again, when you check the news 2 score, if it is more than 7 or above, that means it's red. That is a red flag, or that is definitely sepsis, and you need to start the Sepsis-6 bundle. So here news 2 is 7 or above, or is news 2 5 or 6, and so if it is 7, definitely it's red. Now if it is 5 or 6, and then you have to see any of these points. So any one of these points, if it is positive, then also you need to consider as red. So any of the news 2 parameter with score of more than 3, mottled or ashen skin, non-blanching rash, cyanosis, deterioration since the last assessment, deterioration since the recent intervention, lactate more than 2, or a known acute kidney injury. So any of this point present and news 2 is 5 or 6, that means you need to consider it as a red flag, or you need to start the Sepsis-6 straight away. Now, when news 2 is 5 or 6, or news 2 is 1 to 4 plus one of these. You can see another 5 points over here. Mottled, any of the news 2 parameter score of 3, mottled or ashen skin, non-blanching rash, cyanosis, deterioration since the last assessment or recent intervention. Any of these present, news 2 1 to 4, or news 2 5 and 6. Then it is considered as an uh, amber flag or moderate risk. Then we have to send a full bloods, consider discussing with the senior, and if antimicrobials needed, can be given within 3 hours. You have little more time over here. Sepsis 6 is again, once it is a red flag, it is an emergency. So let's see. So again, organ dysfunction, we have discussed about one score called SOFA in the earlier slide. So this is the complete SOFA score. This is the definitive definition. Clinically, this is the definitive definition of sepsis, but many a times it's kind of difficult to do it straight away in the triage or straight away in the red zone because it requires few investigations. If you have a point of care testing, then well and good, you can get it and easily score it out. You have respiratory things, respiratory parameters like PaO2 by FiO2, which can be easily obtained if you have arterial blood gas analysis. Then we have liver function test. So you need, so you have bilirubin, which is again, which comes as a parameter. Again, you can see scores based on the amount of bilirubin. Then you have nervous system. Again, clinically, if GCS comes over here 13 to 14, scored as 1, 10 to 12 scored as 2, 6 to 9 is scored as 3, and less than 6 is scored as 4. Coagulation parameters, here platelet comes over. So again, platelet less than 1.5 lakhs or 150, 1.5 lakhs is considered as 1, less than 20,000 is considered as 4, and less than 102 and less than 50,000 is 3. Now another parameter is the cardiovascular system MAP comes over. MAP less than 70 is 1. Now receiving dopamine less than 5 micrograms is 2, dopamine more than 5 microgram per kg per minute or epinephrine, norepinephrine is 3, dopamine requirement more than 15 or norepinephrine more than zero point 0.1 is considered as 4. And finally, a renal system parameter creatine comes over. Creatine score of 110 to 171 more than 440, and their urine output also comes in. So 500 ml of urine output per day is less than is 3, and less than 200 ml urine output per day is 4. SOFA score is a little extensive. Then we have also one score called QUIC SOFA score. Here there is, it's a quick screening tool. So we have any documented or suspected infection, a patient coming in with an infection with 3 components. Uh, we have altered mental status, that is GCS less than 15. We have respiratory rate more than 22. And finally, we have systolic blood pressure less than 90. So 3 points. If score is more than 2, that triggers again a sepsis. That's a good screening tool for sepsis. QSOFA is a screening tool for sepsis, but SOFA is a diagnostic tool for sepsis. If more than 2 among this SOFA is present, then you need to consider um, sepsis. Now, we were at Sepsis-6 bundle. Now, we'll discuss about Sepsis-6 bundle in detail. What are the 3 therapeutic and what are the 3 diagnostic steps? So it's more like take 3 and give 3. What are the 3 things what we take and what are the 3 things what we give? So the 3 things what we take are we take a blood culture, we take the urine output as a measurement, and we also take, so blood, we take urine output, and we also take lactates. And what are the 3 things what we give? We give antibiotics, we give IV fluids, and we give oxygen if required. So now 6 steps, if you can look at sepsis is a complex condition. It requires it requires a lot of experience in managing sepsis because a lot of decision making comes over. So we need to, the first step will be to ensure that the senior clinician attends. In the UK setting, it will be like a ST3 plus or equivalent senior nurse. But then definitely in all other systems of care, a senior consultation is required. Second step would be to give oxygen if required. There is critical imbalance between oxygen supply and mismatch and demand in sepsis. Correcting low saturation helps in improving tissue hypoxia. So our target oxygen should be 94 to 98% as an SpO2. Start oxygen if it is less than 92. Now, if there is risk of hypercarbia, that is your hypercarbic or hypercapnic respiratory failure patients, like for example, COPD patients, usually we go for a target of 88 to 92%. Now, the third step, we obtain an IV access as soon as possible, take bloods. The bloods, what we take include blood culture, you take glucose, blood glucose, lactate, total counts, we also take a CRP, an LFT, and a clotting parameters, and urea and creatine for the renal function test. We may have to consider lumbar puncture along with that if we are suspecting a meningitis. These laboratory tests or the blood cultures help us to risk stratify the patient, and we also get to know which causative organism is involved, and we also can modify our antibiotic response and treatment strategies according to that. Now comes the fourth step, that is to start off with IV antibiotics. So IV antibiotics, we go for broad spectrum antibiotics. Along with IV antibiotics, starting IV antibiotics, we also go for source control. For example, if this is related to a catheter related or a tube related or an insertion related infection, like for example, uh, an nephrostomy tube or a catheter, urinary catheter. So it also include source control, so removing the tubes accordingly. Broad spectrum antibiotics are suggested according to the local policy and as well as the allergies what patients have. And to add on antivirals, again, that is according to the infection specific and the patient specific as well. So controlling the infection with an antibiotic will help in reducing the stimulus to the immune response. As you all know, sepsis is a multi-system response. There are a lot of physiological changes what happens during sepsis. There is a lot of fluid loss. Fluid gets lost as well as fluids can be found in places which is not supposed to be a. So septic shock is a distributive shock. There is increased vascular permeability. There is third space fluid loss. So we also have to give IV fluids as a fifth step. So IV fluids, we can start at 20 ml per kg in divided boluses. For example, we can start off 500 ml fluid bolus, see for the response, give another 500 ml. It goes like that. Always to keep in mind about fluid overload. So lactate can be used as a measure to guide the fluid resuscitation. So hypovolemia, again, as we know, there is an absolute as well as relative hypovolemia, which causes septic shock. There is third space fluid loss. So we can restore the fluids. Now discussing about the fluids, what is the fluid of choice? So as we all know, 0.9% normal saline as well as Hartmann's or Ringer lactate is effective. They around 30% stay in the circulation. The advantage of Ringer lactate is that it does cause hyperchloremic metabolic acidosis, but then there is potassium in Ringer lactate. It has to be used with caution in already patient who's having hyperkalemia or suspected to have hyperkalemia. There can be, especially in patient who's having acute kidney injury. Normal saline doesn't have potassium, so I mean there is no increase in potassium, so it can be used effectively. 20 ml per kg. So one thing which has to be remembered, colloids except albumin doesn't have any role in management of sepsis. Even though theoretically it stays more time in circulation, it doesn't have any role. The role of albumin is currently being studied. As of now, the main disadvantage of albumin is that it's quite expensive. Blood transfusion, especially, can be used to if there is significant anemia present. Now, final step is to monitor. The news too can be used to monitor the patient. An important parameter to monitor during sepsis resuscitation as well as continuation of the sepsis resuscitation would be to monitor the urine output. This may require a catheter insertion. Lactates can be repeated at least hourly if the initial lactate is elevated, that is more than 2. So you find the lactate more than 2, you give fluids, you repeat the lactate. That's how it goes. Lactate can also be repeated if the clinical condition worsens. Now, sepsis is a dynamic state. Urine output and lactate, now as we discussed, will guide the therapy, and they also will guide the need for ICU admissions. So in short, Sepsis-6, if you can see, senior health, that is a senior clinician or senior expertise is required, oxygen if required, IV access and blood cultures, IV antibiotics, IV fluids to be considered, and finally monitoring is required. So that's the Sepsis-6 bundle of sepsis. So we spot the sepsis, treat it, and beat it. So that's the motto. Now coming to septic shock, as we have discussed, septic shock is a subset of sepsis and it causes major circulatory and metabolic irregularities or abnormalities. Our target will be to keep the MAP above 70 or above 65. So here we'll have to start off inotropes and vasotropes. Inotropes are indicated if there is associated cardiomyopathy. Sepsis is known to show the cardiac depression or cardiomyopathy. So associated cardiomyopathy present, a left ventricular failure present, you may have to start on with inotropes. Vasopressors are also indicated if the blood pressure doesn't come up even after administration of fluids. The first line inotrope of choice is dobutamine. If there is an evidence of myocardial dysfunction, such as a low cardiac output, even though after giving adequate fluid resuscitation and there is no increase in the MAP. Vasopressor is indicated for maintaining the blood pressure. So first line vasopressor is norepinephrine. Alternative agents or for refractory hypotension, you can give epinephrine or milrinone also can be considered. Now to sum up, sepsis is a multi-system problem. The treatment of sepsis for patients with sepsis are identical regardless of the cause of it. Like you can see, we have seen many causes, but the treatment is the same. Initial assessment and resuscitation should follow the ABCD format. Now we have to apply the sepsis screening tool as we have seen as well, the appropriate one, and patients should be managed according to the Sepsis-6 approach. So that's all what we had in this short discussion. Thank you all.